Hello everyone, this is Dr. Pruett. Today we're going to be talking about airway tips and tricks. And I realized that we do not intubate that much as a system, and so I thought it would be nice to do a little review of some airway management basics and then some little tricks that I find helpful when managing an airway to maximize your odds of success. Just like with everything, the basics are going to be so important to your success in managing an airway, and I think we're actually very good at this. But understanding and mastering the ABCs, airway, breathing, circulation, and everything in pathophysiology comes down to oxygenation and ventilation, which keeps the body alive, right? So oxygenation is the ability of the body to deliver oxygen to the tissues. In order to do that, you need to be breathing in oxygen, have that lung be able to distribute the oxygen via the capillaries to the red blood cells to then get delivered to the organs. And ventilation is a little bit different. This is the actual physical act of breathing in and out. And sometimes there's problems with one or both of those things. If it's a problem with oxygenation, sometimes all we need to do is provide a little bit more oxygen and then things get better. Typically, problems with ventilation are a much larger issue that needs some active control. And one of the ways that we actively control an airway is with a bag valve mask. And this, I would argue, is a much more important skill to be able to do than the act of actually intubating, because you can manage most airways with this without having to actually visualize the cords. If you are very good at this skill, you can absolutely save a life and be able to oxygenate and ventilate someone for quite a while. So I would encourage you to practice this skill when you get a chance and become experts at it. It's absolutely very important to any practice of pre-hospital medicine at any level. So the way I like to teach bag valve masks, this is for a patient who may be unresponsive or is not breathing adequately on their own, and you're needing to take over that airway and breathe for them, provide oxygenation and ventilation. Ideally, you're going to have two people, so you'll have a partner, and the reason why that would be helpful is you can do the 2 thumbs down technique. So if one person is standing at the head of the bed and their whole job is to make sure that their mask is sealing the mouth and the nose to provide oxygen into there, and there's no air leaking around the face, but actually going directly to the lungs where it should be going. And the best way to get a seal and to control that mask is to use those 2 thumbs down. And if you see in this picture here, the 4th and the 5th digits of the person controlling that airway are wrapped around the angle of the mandible. And it's very important when you're doing this to think about lifting the face into the mask and not smashing the mask onto the face, but using that 4th and that 5th finger and use that angle of the mandible as kind of a hook to lift the tongue and lift the jaw off the back of the throat to make a nice big airway passage for air to go in. And then the partner can be actually compressing the bag to provide the ventilations. If you're having difficulty with a mask seal, or maybe there's some anatomical difficulties with the patient, it's always nice to consider your airway adjuncts. So you can use a oropharyngeal airway or NPA. And then 2 inches of head elevation will line up the airway nicely. We'll talk about that in a minute. And then remembering it's always very tempting to breathe very fast. This tends to be a stressful situation. But if you can slow yourself down and do 2 seconds per breath, so 1 1,000, 2 1,000, and that's how long you're squeezing for, and then release for 3 seconds, that will give a nice volume and a nice respiratory rate that is good for your patient. So when we're talking about head positioning and the positioning of the jaw and the tongue, really in any patient that you're having to provide ventilations for, the tongue is kind of going to be your enemy. So it's this big, thick muscle, and when a person is so relaxed that they're unconscious, that jaw tends to relax into the back of the throat and can actually occlude the airway. So you see the air coming in from the nose here, from the mouth here, but with that tongue so relaxed and the patient laying on their back, it collapses the airway and makes it really hard for air to get into the trachea. And so there's different maneuvers that you can do to help open up that airway and facilitate ventilations. One of the easiest ones is a head tilt chin lift, and you can see here it's demonstrated nicely with this man who is unresponsive. You can see his tongue occluding his airway here, and it's difficult for some air can still get through, but it's not a nice open passage. Whereas by just tilting his forehead back and his chin up a little bit, that movement pulls the tongue off the back of the throat, and much more air can naturally be delivered into the trachea and help with oxygenation and ventilation for him. Now, of course, with the head tilt chin lift, you need to be careful in any patients who might have a suspected C-spine injury, so this is not recommended in our trauma patients. The maneuver in trauma patients that we teach is the jaw thrust. And it's the same idea without having to move the neck, is just lifting that corner of the jaw. It provides a nice little handhold there right in front of the ear to physically lift that tongue off the back of the throat so air can get into the lungs where it needs to go from the nose and from the mouth. Another thing that I really like to do in unresponsive patients, and this will be also very important as we move on to intubating a little bit later, but the ear to sternal notch. This is a really good eyeball thing that you can do actually from across the room to assess how open a patient's airway might be, and you can actually use your stretcher to help with this, or maybe some pillows or blankets to adequately position your airway to provide optimal oxygenation. But if you take the meatus, the whole of the ear right there, and just kind of draw a straight line to the middle of the chest where the sternum is, so the ear to sternal notch. If you can make that a flat plane parallel to the ceiling, what that's going to naturally do is force that tongue off of the back of the throat and optimally position that airway so that maximal air entry can come in. It's a really nice trick to help your patients that are maybe having some sonorous respirations or snoring or occasionally occluding due to a large tongue or maybe a heavy neck. Just simple positioning can go very far in helping you with some oxygenation and ventilation. Again, more strategies to combat the tongue in the back of the throat to facilitate oxygenation. We're all familiar with the nasal airway, and you want to measure from the tip of the nose to the tip of the ear. Important to note that these are not used in patients with facial trauma because there's a risk of potential brain injury there. So be selective in the patients that you use them for, but it does help facilitate oxygen entry, get kind of past some of that posterior oropharynx obstruction with a tongue that may be in the way. Again, I always try positioning first, but if you need to, and this is just a difficult patient with difficult anatomy, these can be a nice adjunct to your treatment. One important thing to consider with these is we talk about sizing, and the minute you're handed these, you learn about the importance of it. This is actually a patient I took care of in the pediatric ER who had one placed prior to my assessment, and she made it over to the CAT scanner, and you can see here that it's much too long. Here's the edge of her nose, and you can see the edge of the NPA, but if you follow the NPA all around you can see it's pushing her tongue out of the way. It's going directly towards the trachea, just like you want it to do, to help open a passageway for air to come through. But if you look really closely here, what it's doing, because it's sized inappropriately, it's much too large for her face. It's actually pushing her epiglottis down and occluding her airway. So when you're using these adjuncts and you think that they're helping, this adjunct is actually causing a much bigger problem for her than helping, because it's pushing the epiglottis down over her airway and occluding her airway. So all of that air that we would think that is going in, it's probably going directly into her stomach. Now, we did catch this pretty quickly and were able to correct it, but I think it's a really good visual of why it's so important to accurately measure these things before you do it, because it can cause harm. They're not harmless tools that we use. Oral airway is another adjunct you can use. This is for your truly unconscious patients. You absolutely need to make sure they don't have a gag reflex before you shove this in their mouth. But if they do not have a gag and they're truly unresponsive, it can help. You can see it's shaped to move that tongue off of the back of the posterior oropharynx to help facilitate some ventilations. Now, I would argue if they're sick enough to need an oral airway, you might want to just consider moving to a supraglottic right away. This will actually is a device that can get around the tongue and directly deliver oxygen, and also only to be used in patients without a gag, but I think it's a much simpler device to use, and if you're considering using an OPA, you might use that to just buy yourself some time to get the supraglottic ready for administration, because that's going to be a quicker and easier device to use. And here's just a picture of what that looks like once it's inserted. So very easy to insert. I know we get a lot of practice with these, but you lift the jaw and the tongue off the back of the mouth. You make sure they're sized appropriately based on estimated patient weight, and the sizes are conveniently labeled right on the package, and you just insert it in until it stops and kind of takes a seat. The eye gels are pretty nice because you don't even need to inflate a cuff anymore, but it basically provides air, occludes the esophagus, and if it's placed correctly, and then provides ventilations directly into the trachea. One of the more common issues with supraglottic placement is the temptation is, if it's not working right or if it doesn't feel like it's seated right, to push it in a little bit farther. And actually, one of the better ways to troubleshoot these is try pulling it back first, and usually that helps. Usually the error is that it's in too far. And if you're having an issue, try pulling it back. I know it's counterintuitive, but sometimes that will help as you're trying to measure your ventilations and make sure that they're adequate. When you're using any kind of airway device, whether it's a bag or a supraglottic, if this is an unconscious patient without a gag, there's always a danger of overinflating the stomach with air, and that's going to do a couple of things. It's going to take up a lot of the volume in the chest where you would like air exchange to occur. It's going to be displaced by a distended stomach. And not only that, but a distended stomach, if it decompresses for some reason, you can end up with a lot of vomit in your airway, which nobody likes. So in airways that you're actively having to manage in unconscious patients, if you have time and think about it, using a orogastric tube to suction out the contents of the stomach, whether that's just air or whether that's vomit, that's going to give you the added advantage of increasing the volume in the thoracic cavity, where you can ventilate a little bit better and provide yourself some relief and help yourself out there if there's time for that and you have the right equipment. If for whatever reason you've decided it's time to move on to intubation, you want to make sure, once you've made that decision, that you're going to actually intubate this patient with direct laryngoscopy. Equipment check is going to be key. So while you're setting yourself up and checking everything, make sure you have someone who is bagging adequately and very well. You always want to have suction ready to go. And then end tidal is an absolute must. So as soon as that tube goes through the cord, the next move should be hooking up the end tidal and making sure everything is working. Always check your light on your laryngoscope before you get started. Your ET tube, most adults, I would say, can take between a 7.0 and an 8.0 ET tube. You want to be sure that the cuff on the end stays inflated, so have your 10cc syringe close by, test your cuff, make sure there's no holes in it, and then it will stay inflated and can hold the air. I also like to either have a stylet or a bougie. Truly, the airways that we're managing in the pre-hospital setting are some of the most complicated that you'll ever see. And anything that you can do to set yourself up for success on your first pass, I would encourage you to do. And so try to get used to working with a bougie. Study after study has shown that if you train with a bougie, it helps in the most difficult airways to get you in the right place to place your ET tube. If you're having difficulty with visualization or just a difficult airway in general, the bougie is a very nice tool to help with first pass success. And just like I mentioned before, I cannot emphasize this enough. If you take a couple extra seconds to set yourself up for success, one of the most important things you can do is the position of the patient's head. So if you can line up that ear to sternal notch before you even get started, you're basically going to have a much more direct line of sight into that patient's airway than you would before. So what you want to do is have the face parallel with the ceiling, have the ear as parallel as you can get it with the sternum, lift that head up off the back of the floor, and it's really going to help with what you're able to visualize when you take your look with your laryngoscope. And once you've checked all your equipment and you know that your patient is in the optimal position, or as optimal as you can possibly get it in the field, I know some of these scenes can be a little crazy, don't start intubating until you've pre-oxygenated and have a saturation that is adequate to go ahead and stop ventilations for a second while you take your look and try to pass your tube. So pre-oxygenation is incredibly important. You ideally want to not intubate until your saturations are close to 100%. Now, I realize not all conditions are ideal, and so you do the best that you can do in the circumstances that you're in, and you do your best to pre-oxygenate before you pass that tube. One thing you can do to buy yourself a little bit longer look before your patient desaturates is apneic oxygenation. So if you're able to set up a nasal cannula with high flow that's passively oxygenating your patient while you're taking a look with your scope, this has been shown to prolong the amount of time that the intubator can actually take a look and attempt this procedure. So apneic oxygenation is a very nice tool, and I would highly encourage you to use it if you have it available or have the time. And once you take a look with the scope, so you go in, you're holding the blade in your right hand, you already know that your light works, you have your ET tube ready, you have your capnography plugged in and ready to go. As you go past the tongue, I would encourage you, as you look into the mouth, go slow. Identify everything you can on your way to the epiglottis. So, and you can even tell yourself, this is the tongue. Okay, there's the uvula. Okay, there's the epiglottis. And if you go slow enough, you'll be surprised, but slow is smooth and smooth is fast. And so identify every possible structure you can on your way into the patient's mouth until you find the epiglottis, and that's truly what you're looking for. And once you find that epiglottis, then you should be able to lift it up using that hyoid ligament and visualize the vocal cords. And what you're going to do if you're using a Mac blade, remember you can use the Miller to just lift the epiglottis out of the way, but if you're using the Mac blade, you want to engage that ligament right above the epiglottis. You can see it right here on the left, and if you hit it right in the middle with the tip of your blade, it opens that epiglottis just like a door. And then you can see back here, you see your posterior arytenoids, and you see both of your vocal cords here, and that's your target where you're going to pass your tube through. Another tip for success, so in addition to making sure that your ear to sternal notch is completely lined up and your patient is optimally positioned and you have your apneic oxygenation going, the next thing you can do to set yourself up for success is remember that intubation is a two-handed procedure. Okay, so you can have a partner hand you your tools if you need to, but really you have the blade in your left hand that's really looking for that epiglottis and looking for your vocal cords. If you can take your right hand around, and this is called bimanual laryngoscopy, but push on the neck. You push down and up, and what that's going to do is move the vocal cords into your field of view. And once you get them in your field of view by pushing down and up, it's not cricoid pressure. You're actually manipulating the larynx into the position you want it to be. You can grab your partner's hand, place them exactly where you want them, and they can hold that there for you. And then you can maintain your view while you pass your tube. And that's called external laryngeal manipulation, ELM. And a recent study just came out. Actually, this one was in 2002, but there's been some more recent studies that have shown that just by manipulating the larynx alone, so remembering that intubation is a two-handed procedure, here are some pictures where they demonstrated this. So in this one, they had a 0% view, right? You can see the tip of the epiglottis, but you can't see arytenoids, you can't see vocal cords. And over here, by just pushing down and up on the larynx, they improved their view by 61%. Same thing here. There's less than a 20% view here. You see your epiglottis. You can barely see your arytenoids. But here they're doing external laryngeal manipulation again. They move that airway into their field of view, and it improved their view by 63%. And then over here, same thing. Very poor view still. Maybe some posterior arytenoids here. You're starting to see the base of the vocal cords, but just by manipulation here, you can increase your view by close to 50%. So very important technique to help yourself there, and I would encourage you to practice it. It's easy to forget because you think that blade in your left hand is going to do everything for you, but don't forget, usually that right hand is just standing by your side. Don't forget to use it. Intubation is a two-handed procedure. Couple other things I'd like to encourage you to do. These are some common mistakes I see in the field. One is preloading the Bougie with the tube. I know it seems fast and it looks kind of cool, but one of the reasons we use the Bougie is because it gives you tactile feedback. So you're supposed to feel the tracheal rings. If you're in the right spot, you should feel the railroad tracks of the tracheal rings as it goes down. And then it has a hard stop if you hit the carina, right? If you're in the esophagus, it's going to go all the way into the stomach. But if you're in the right spot, you feel the tracheal rings, you feel the hard stop at the carina. Problem is, if your hands are over the tube that's covering the Bougie, you're going to lose at least half of your tactile feedback. And not only that, but if you're needing to move the Bougie forward or backward or whatever, you have no positive control over the Bougie because you're only holding onto the tube and it's very slippery. And so I would encourage you to not load your tube over the Bougie until you're sure that the Bougie is in the correct place, much like you see in this picture here. So this person has the blade in their left hand. They've probably visualized the cords. They found where they want to be. They've pushed the Bougie through the cords as a placeholder. And the other thing that I see that we commonly make a mistake is you feel like once you're through the cords, your job is done, and it's really tempting to remove this blade. Don't do that because it's still holding all of those very heavy, very bulky soft tissues off the back of the throat. And so keep the blade in place, keep lifting with your left hand, and have someone else thread that tube for you. Please leave the blade in the mouth because it will make your job easier because you still haven't passed the tube through the cords yet. And speaking of passing the tube through the cords, this is another trick that I find very helpful. I call it BLT, Bougie left turn. So as you're trying to thread that tube over the Bougie, it's very easy to get caught up on this arytenoid right here. If you look at the bevel on the ET tube, it's perfectly positioned as you thread it to get stuck right here. And so if you can imagine, as you're coming in the mouth, your Bougie is through the cords. You know you have optimal positioning, but you're trying to get that little bit wider ET tube to go through the cords as well, and it keeps getting hung up right here. All you have to remember is Bougie left turn, and you just do a counterclockwise turn or turn to the left with the Bougie and the tube, and it'll literally just rotate the bevel of this tip of the ET tube directly into the trachea where you want it to go. Bougie left turn will help you get around that arytenoid that it loves to get caught up on. Another trick that we introduced into the guidelines just this year is called salad, and this is basically a very difficult airway that's either full of blood or a lot of vomit. It's okay to directly position your suction apparatus into the esophagus and just continually suction whatever is coming out of that airway while you're still trying to obtain your view. It's going to give you a little bit of a clearer view, going to decrease your amount of time managing the secretions and still allow you to take your view and try to get your ET tube around all of the secretions in that airway. It's called salad. Very important reminder here, anytime that you are intubating a patient with an ET tube, you must have waveform capnography documented and able to print out at any time. This is the gold standard for confirming ET tube placement. I understand that misting in the tube and bilateral lung sounds and absent epigastric sounds, all of those are very nice and reassuring to have to confirm the position of the airway, but the only thing that truly tells us where that airway is and if it's effective is waveform capnography that's continuous. And so anytime you are intubating a patient, you must have this documented and able to be printed out. Another nice thing that we have in our system is a Parapack. If it's available, please use it. Please get familiar with it. Their studies have shown that controlling the rate and controlling the volume of respirations is better for patient outcome, and this just takes one less thing off your plate and trying to manage your patient. If you can hook them up to the machine and let the machine do it for you, they're very reliable and consistent. Just make sure that the oxygen is still flowing. You don't want to see that red ball there. And if you have questions, I'm sure you can reach out to the 7-8. They'd love to go over it with you. But please don't be afraid to use it. It's a really nice tool to have in the toolbox. And of course, after we intubate patients, if now that you have improved their oxygenation and their ventilation and they're starting to wake up or become a little bit more combative, you also have some tools in your toolbox to make them a little more comfortable. It's not very comfortable to have a tube in your throat that's breathing for you, and so if you need to give them some sedation or some pain control, that's absolutely okay. I tend to start with fentanyl first, just because it is easier on blood pressure and doesn't really have untoward side effects. So ketamine can be used by AAS, but it may make the secretions a little bit worse. At this point, that may be less of a consideration because you do have a definitive airway. Versed is another option, but just be careful because it can lower blood pressure, and so I tend to go to fentanyl first and maybe just an aliquots of 50 micrograms for an adult every 5 minutes or so to help them calm down and treat their pain. Now, if you do run into problems with your ET tube, just remember the DOPE mnemonic, displacement, obstruction, pneumothorax, and equipment failure. These are some things I work through when maybe you're having trouble ventilating or your patient's oxygenation is dropping. You want to really confirm that tube placement right away. I usually disconnect them from the ventilator and try to bag and feel how tough that bagging is. Is there potentially an obstruction in there, like a mucus clot, or did the tube, is the patient biting on the tube? Maybe there's a pneumothorax from too much pressure. All of those things. So reevaluate your lung sounds, reevaluate your patient sedation, reevaluate your equipment, make sure that balloon is still inflated and you're not having a leak somewhere. Those are all ways to troubleshoot your ET tube. At the end of the day, if you can't troubleshoot it and you're not sure that it's right and you can't confirm it's still in the right place, the right thing to do for that patient, if you're still not able to oxygenate or ventilate and can't figure out the problem, would be to pull the ET tube, try a Supraglottic, or just bag until you get to the hospital. Just remember, vital signs are vital. Please, before every procedure or anything that you do, get a set of vital signs going in, and then a repeat set of vitals after you completed your intervention. And then especially with any kind of airway management, end tidal is going to be the key to everything that you're doing, so make sure you're monitoring that and then keeping a close eye on the saturation. They can change very quickly, so make sure you're constantly reassessing them. And that is all I have. Please feel free to reach out to me if you have questions. I'm always happy to talk about this. I hope after today's talk you found some helpful tips and tricks for the next time you have to intubate. Thank you.